Hello everyone and welcome in today's nursing webinar session. And today the topic we are going to talk about is robotic surgery and nursing management. Imagine the robots getting inside the operation theater and performing the surgery. That's how we are going to talk about the robots today. So let me just welcome myself, Shanti Bhattacharya, the Vice President, Yashoda Hospital. And let me take the opportunity to welcome our very young, eminent, and very highly competent panel expertise, Dr. Sunil Dachepalli. He himself is a senior consultant, robotic joint replacement and arthroscopic surgeon from Yashoda Hospitals, Somajiguda. And when I think sir do not require any kind of introduction, he is very eminent and very famous everywhere. So from the past, within the 3 months, I think sir has already performed more than 100 robotic surgeries. I welcome you, sir, in today's nursing webinar session, and thank you for taking the webinar invite. Thank you. Let me also introduce our very dynamic and efficient senior nurse manager, Sujatha, and she will be our speaker today. So today we are going to talk about a lot about the robotic, how it is done, what are the nursing aspects, and how patient has to take care. So the very first question which I would like to ask to Dr. Sunil is, sir, what is your view on robotic assisted joint replacement surgeries?
Yeah, thank you all for having me today. And good afternoon, all of you. I hope you're not sleeping. It's already 3 o'clock post lunch. Robotic is the new advancement in joint replacement, as you all know. We have been doing joint replacement since almost 1960s. So ever since I worked in the first hospital where the joint replacement was performed, and the best part was the place I worked in UK. The first joint, which was done in 1966, some of them have revised them. That is, revision is when they become loose, you change it. And guess when? I've done that in 2006. So the gentleman who was done initially, that has lasted for 40 years. Now, the most important thing is not all joints last that long. Some fail within 1 year, 2 years, 5 years, 10 years. So the aim of the improvement in joint replacements is to improve the longevity, improve the movements, and less pain. So that is why the improvement in the technology and also the evolvement. And there are lots of things in the joint replacements. The robotic is one of the latest ones wherein we see the precision is much better. So I'll put you in a simple way. Like a lot of us, we have seen how the houses were planned when we were kids. It was like you see a blueprint. And then once you construct your house, then you put all the colors, you got your house ready. Then you realize, oh, suddenly I didn't want this one here. I want to change this one to that place. So what do? You knock it off and redo. So that takes a lot of time, waste of money, expenditure, and also time. Now, the current house planning is 3D. Before you even start your house, you see a 3D structure, the colors, where you can park your car, where you can have your plantation, all these things. So you can change there itself. You have a idea as to what your house is going to look like. Then you execute. Thereby you're saving time, energy, money, lots of things. Similarly in joint replacement, now when I do the regular ones, conventional they call it, I come to different steps, I have to recheck, and then accordingly again make changes, again keep doing, and if I don't like, go back to step 1. So there's lots of process. Whereas robotic, it's made simple. I do all the planning even before I cut the skin. So thereby you plan, you just execute, and the end product is also ready. So that is why it saves a lot of time and also less pain. People are walking quicker within 4 hours. So that's a win-win situation for everybody.
So it's a very interesting, as you said, we are looking at the longevity of the patient's surgical site, etc. So let's explore more about it. Over to you, Sujatha. You can start this session.
Yes, ma'am. Very good afternoon. And thank you for your sweet introduction, ma'am. And I'm myself Sujatha, working as a senior nurse manager in Somajiguda Yashoda branch, ma'am. And welcome my dear viewers, and this is very good afternoon to everyone. Okay, today I'm going to discuss about robotic advancement in orthopedics and which is related to nursing and your advancements. Yes, robo is performing surgery, or human robo is robo or machine. Which one is in our thoughts? Yes, what is robotic surgery? Robotic surgery is currently carried out with the use of the Vinci surgical system, a unique set of technologies that include specialized arms for holding instruments and camera, as well as a magnified screen and a console, the one who operates the consoles.
So here I would like to again ask one of the very interesting, mindset which nursing or any layman would think is when it comes to the arms. So are they robotic arms or sole enough to apply the surgical intervention or guidance to the arms? What are your take on this, sir? How do you program this?
Yeah, I mean, we have two types of robots. One is fully automatic, the other one is semi-automatic. Fully automatic is as if you open up the knee joint, like you've seen here. You grip nicely, open up the knee joint, you attach to the robo console, and that does the job, majority of it, because I plan it much before based on a CT scan. So I plan, attach the leg to the robo arm, and let it execute. So that is fully automatic. The one we have here is a semi-automatic, wherein I have the control. If you see this slide here, you can see there are three of these TVs there in front of you. One is the actual TV, the other two are belonging to the robo. So there I get to see the 3D vision, and then based on that, I have the control. I can execute based on the appearance and as to how the robo guides me. We feel this is much more safer because see, at the end of the day, it's a machine. It's just robo and it can execute. Sometimes it can go wrong. Whereas handheld, I have the control, so I can stop when I want to. So this is the setup we have currently.
So would you also like to go for the second slides as well and explain us what are the setup we have in Yashoda Hospital?
Yes, I mean, this is one of the most advanced robo that we have here. And what you can see from the top, you can see a horizontal bar with two eyes. These are the eyes, the sensors. What it does is it senses the signal coming from the, if you go back to the one slide before, please.
Sujatha.
Can we go back?
Yes.
Yes.
So we can see that we have the arrays just placed on the right next to the iPad there. Okay, next one, please. So what it does is that is placed on the body, and we fix it with the pins onto the bone, and then we put the sensors, and that is received by the camera that you see horizontally. Below that is the big screen where you have the actual original 3D orientation that is developed by the robo. And underneath there, you see a iPad that is kept near to the surgeon. Below that is the actual robo machine. That is the actual brain of the machine. And underneath that, you can see the foot pedals that I need to execute. And you can see the wheels as well. Because the beauty about this is mobile, much more mobile and less heavy compared to the other instruments which weigh in tons. We're lucky to have this latest machine at Yashoda. And this is the handheld one that we're using.
So I think these are the functions of camera and as well the console, you mean to say, sir?
Yes, the cameras are that you can see on the top. Like,
yes,
you know, it's almost like artificial intelligence. And these cameras take the real-time view from that sensors that is attached to the body. Initially, I have to tell the robo what is I map the bone. So it takes and it forms a picture. Then it has the visuospatial orientation, and then it will give you a real-time guidance in the screen. When I'm doing the cuts, it will tell me how I'm cutting. If I'm going beyond the plan, it will stop. It won't go further. So that's the beauty.
So these programmings are already taken when the patient is already entered in the theater and you're already doing the programming and then you're going for the surgery. Is it so, sir? This programming is done before the surgery is taking place.
Yeah, your voice broke up in between, sorry. Now
This programming, I repeat again, this programming is taking place before the surgery.
yes, I mean, see, there are two different types. One is you plan based on the CT scan. We call it image guided. The other one is imageless. Image guided is the day before or a couple of days before you take a CT scan, send it to the lab. They make a plan. They send you the plan. Then you, even before you go into the OT, you sit on your laptop and then make all the plan, whatever corrections, feed that to the robo. Then you start. So this is the fully automated. Whereas the ones we have is semi-automated, like I told you. So I do the planning. So you don't waste time on unnecessary CT scans. It's more expensive and more radiation. So here we get the real-time view. So I do the mapping. As soon as I go inside, I open up, tell the robo, this is the knee joint. We make the movements. And then I mark, like you view a stencil with a pen. We draw the bone on top of that original bone. So the robo will make a map of it and makes an image. So this is imageless. So that you execute, wherein you make the plans, how you make the cuts. Once you have done all the planning, then you say start. Once you say start, then I hold the cutting tool, which is either saw or we call it burr. So that is how we cut the bone. I use that, but when I go beyond the planned margin, it stops. It doesn't go beyond that.
So over to you, Sujatha. Can you just go for the next slide where sir can also provide his input? Sir, is this with handheld robotic device, I guess?
Yes, this is the one we are talking about. You can see the handheld, and the one that is touching the bone is called the burr. Okay, and we hold it to cut the bone.
Next slide. This is, I think you have already mentioned that you plan with the CT scan guided prior to. Next slide.
Absolutely.
What is this about post-op gap assessment or a range of motion about, sir?
Yes. Now, the importance of doing a joint replacement, not only having a stable joint, but also with a good range of movements. See, they expect in India, they expect to sit down on the floor, like a squat on the floor. So we want to get the most range of movement. So as you see here, almost my flexion is almost full. See, if you look at the top left-hand corner, 123 degrees, which is almost you can squat on the floor. So not only the implant positioning that you have seen initially, wherein I have to get the appropriate size and also see whether that's stable, then move over to, when I move this, I'm checking whether I'm getting good movements and also stable in all the directions. Sometimes when you're bending, see, this is a mechanical thing that is there. When you're bending, if it's loose, it'll come out. That's called dislocation. So you don't want that. You want it to be going smooth in all the directions and being stable. So this is what you see. Once we do the planning, and then we check the gaps and everything.
Over to you, Sujatha, for the rest of the slide.
Yes, ma'am. And this is, we are discussing here about what is the use of robotics in orthopedic surgery. And robotic tools make precise movement that preserve bone and tissue and often results in faster recovery and less muscle and soft tissue damage.
So I think you have already explained about the precision about the surgery. And one thing again, we would like to ask or know here is robotic surgical, the entire automatic or the semi-automatic system is AI based, sir?
Yeah, not entirely, but majority is AI based, because that's how the robo is able to get the visuospatial evaluation based on the camera and the sensors. This is like, I don't know how many of you got into Tesla cars. So now if you see Tesla, you have the autopilot mode. Yes. So it is based on lots of cameras. See, it sees the object in front, it gives the feedback. Based on that, the car gets driven. Similarly, if you see in the fully automatic, you just leave it and it does most of the work. So again, semi-automated also, it does majority of the work, but it is held by me. I'm holding the gun. The reason we chose that one is because you have better control. The fully automated, already in Hyderabad, we had some bad incidents in some other hospitals. So that's why, seeing all the feedback, we thought we'll go with the best product, even though if it's more expensive. So currently the one which we have is more safe because the control is in your hand, even though it is AI based.
So, as we were discussing in the slides, that in manual surgeries, do we have more muscle and tissue damage than robotic intervention?
Absolutely, yes. I mean, if you see, majority of my patients are walking within 4 hours. Most of our OT nurses and the recovery nurses, they all know because they're the ones playing the key role. They assess the pain, and the pain team is also involved. And because there's less muscle cuts, less soft tissue damage, patient is having less pain and they're able to walk very quick. And also their movement also has improved. So definitely Robo has a better chance.
What is Sujatha?
Yes, ma'am. And robotic orthopedic surgery is a game changer together, moreover. And during the joint replacement procedures, a surgeon cuts away damaged bone and cartilage together and replaces it with the artificial components made of metal alloys and high-grade plastic and polymers. And also, one of the most difficult aspects of this joint replacement surgery is placing individual components of the artificial joint in the best alignment position, actually. And so they will mesh together and work smoothly.
So,
And yes,
please correct me. Please correct me if I'm not wrong. As you have already mentioned that programming, and then after your consoling programming, you are able to keep the joint in the situ and then go for the fixation. Is it so, sir?
Yeah, see, what we do is initially we make the cuts based on the robo technology, and then we put what is called trial implants. We have a set of trial implants, but first I put the trials, and then as you have seen, the range of movements, gap balancing, stability, everything we check. Once we are happy, then we open up the original implants, which are sterile, and then we fix it with cement.
Sujatha.
yes, ma'am. The robotic arm provides tactile, visual, and auditory feedback to assist the surgeon in achieving the desired orientation, which can enhance stability and mobility.
Again, we want to know here, how does it takes you to the desired orientation, like whether the surgery is being done or it is halfway, and does it gives you the instruction, or does it display on the screen that something is going wrong, or when it gives you the guidance that it should be, you should be stopped. So we just would like to know, since it is a very interesting session, and not many IP bedside nurses are, they know about it, except the OT scrub nurses and your team. So your opinion on this here.
No, actually, the role is like Mrs. Shanti Bhattacharya, having a stick on top of my head. If I go wrong, it will be hitting me. Okay, so that's the tactile, like Sujatha was saying.
Okay.
I'm just kidding. Now, thing is, like Sujatha was saying, yes, we have the haptic feedback. It's called haptic, wherein if you are holding your smartphones, sometimes when you type in, you get that feedback on your hand.
Yes.
And latest iPhones have the same one, haptic. So it gives you a sense of mild pressure, like, imagine you're playing video games. You get that vibratory feeling. So that's what the gun gives me. So if I am going, like, when you are doing the saw or burring, that is burring is like, like you do for a teeth, you take off the bone stepwise. When I do that, when I'm crossing that area where I want, it won't go further. It gives me the feedback, and also I know that it has stopped. And everything is done on the screen. I see color wise. If I see the red color, that means I have to go further deep. Once I reach the white color, that means I've gone enough depth. So even if I want to push it harder, it won't go further. So that's the best part about the robo. So you won't make mistakes unless you want to.
Sujatha.
Yes, ma'am. And coming to indications, patients who have not had many abdominal surgeries and significant osteoarthritis, varus and varus deformities, and clinically those who cannot perform their daily living activities, these type of people can go for robotic surgery. Yes, and this picture.
Any other indications? Any other indications do we have, sir, in this, apart from these indications?
Yes, I mean, I was waiting for Sujatha to finish this slide also. As you can see, the knee deformities, the varus and valgus.
Yes.
See, all the deformities, the indication for, remember please, indication for a joint replacement is pain. That's the only indication. We get a lot of patients who are like walking like deformities that you see, but if they don't have much pain, we don't operate because that tells us that we still have time. The reason we want to postpone any joint replacement is, if you know each joint, the best joint at the most will give me 25 years. Apart from the ones I told you, 40 years, that happens by very few people. Majority on an average 25. So we want to not to operate as soon as possible. We want to wait. When the patient is having a lot of pain or very bad deformities are coming to the end of their life, then I do the surgery. So indication is pain. Any type of joint deformity we can do with robo. That's the best part about it.
Yes,
Next slide.
in this slide, we can see clearly the normal neutral stance, how the normal human being legs are. And next one is the varus deformity and where the bowel leg shaped it is. And next one is the valgus deformity and where people could not walk and they struggles a lot to walk even normally. And these are the common indications for knee replacement joint surgeries. And this is also the best example. This is neutral stance. The foot always must be stand on the floor in 90-degree angle. If when it is going dorsiflexion or plantar flexion, and this is also a best example for the knee replacement surgeries. And next, we have those so many contraindications also when we are coming to joint replacement surgery. In these type of people, we cannot select the criteria. And severe osteoporosis and gross deformity with multi-ligament injury and other systemic infection people who are suffering with, and we cannot take them for knee replacement surgery as well.
Do we also have any other contraindications, sir, where we should know about this? Yeah.
Yes, thanks for asking that. This is most important. All of you, please remember. Now, the other day, I got a patient admitted in B block, came for hip replacement. We refused to do the surgery for the pure reason he had multiple acne which are infected. So, like Sujatha was saying, systemic infection is the most important thing.
Yes.
But apart from that, any infection in your body, including tooth infection, urine infection, any infection in your body. So that's why we always do the blood test to make sure the white cell count, ESR, CRP are normal. If there is a chance that you suspect infection, please wait. The reason being, joint replacement is an elective surgery. It is not emergency. So this can be done after 1 month, after 1 year, 10 years, 20 years. Once a joint gets infected, the patient is gone because I have to take out whole of the joint, wait for 6 weeks, give antibiotics, redo the joint, and again that might not be successful. So we call it index operation, the first operation. Always we should make sure all the patients are does not have infection. So I urge all of you nurses, you're very clever and you can easily see. So whenever your patient is admitted for a joint replacement, thoroughly examine their body. It's not just the job of that doctor's team or the DMO. Sometimes I appreciate the feedback from the nurses. See, the most important thing, please remember, you are nowhere less to any doctor. See, when I was in UK, I usually coordinate with most of my nurses, and one of them is a nurse practitioner. She operates. Can you believe she does the joint arthroscopies? I have 2 lists. One, I'm doing major surgeries. To my left, there is another small theater where my nurses, they do arthroscopy. Once they're done, they call me. Dr. Sunil, do you want to come and check? So in India, I see that most of you feel that, oh, I'm just a nurse. You're not just a nurse. You've done your nursing training. You've read almost as what other doctors read. You've done anatomy, physiology, biochemistry. You've done most of it. So please be involved. Not only like examine the patient. Some of the nurses tell me the gait pattern, antalgic gait, infections. So at least if you get involved slowly, you'll improve your knowledge. So that is the most important indication not to do is infection in the body. And like Sujatha was saying, severe osteoporosis and gross deformities if it is like at the end of the age. If at all, yeah, like, younger age group, even if it was somebody, I try to do because we have to give them life. Okay, what do you, Sujatha?
Yes, sir. And coming to advantages of robotic surgery and longevity of the material which we used, we can see, and revision rate is very less and less blood loss during the surgery and shorter hospital stay, less anesthesia will be required during the surgery, and quicker recovery, less pain and discomfort, and smaller incision, which is resulting in to reduce the risk of infections. And coming to disadvantages, intraoperative, there may be a chance of having pinhole fracture and laterogenic soft tissue and bony injury sometimes. And if any error is coded to the robot, it may harm sometimes to the human. Yes.
Yeah,
So I think we have seen many of the advantages, but do you agree with these disadvantages, or do we witness these advantages with disadvantages with any of the patients, or in our old case scenario, or what is your opinion on this?
First of all, I should appreciate Sujatha. She has done an extensive job. Now I really feel I'm not, trying to praise her a lot. It feels as if I'm talking to an orthopedic surgeon. That's how beautiful she's done the slides. The precision she has done like a robot. See, advantages is perfect. Disadvantages are very few. Advantages are this: less pain because the smaller cuts, not much of soft tissue and muscle damage. So we are doing sutureless surgery. Instead of putting stitches or clips, nowadays we are using the skin glue. So that is sutureless surgery. So there are lots of advantages with robotic. Coming to disadvantage, again, I agree with her. I mean, most of us have watched the movie Chitti, the Robo too. Sometimes it goes out of control.
Yes.
So similarly, that is the problem with AI. Now, it's all like I said, it happened in outside hospitals with a fully automated. So always you should have control. Whatever robo or AI guided things, if you are in control, then the chance of damages are much less.
And technology also is under control.
Yes, absolutely.
Over to you, Sujatha.
Yes, ma'am. And this is the crucial part in these robotic surgeries, and which we have to take role, and preoperative nurses role in robotic surgery. And basically, minimum fasting of 6 to 8 hours is required, and parts preparation, continue antihypertensive drugs, and withhold antiplatelets before prior to surgery of 5 days, and glycemic control, and prophylactic antibiotic. And coming to role of scrub nurse during perioperative period, organize and ensure all the IPSD goals are repeated before the surgery, and cross-check the concerns, ensuring the correct instrumentation is available to the surgeon, and maintain and responsible for asepsis and to maintain sterile environment. And role of nurse in post-operative period, assessment and reassessment of pain, and supportive cardiovascular stability, and maintain fluid balance, provide wound care and glycemic control, and also DVT prophylaxis, and monitor bowel function, assisting with mobility and early ambulation with physiotherapy.
So how early we should start this physiotherapy and make the patient mobilize, sir?
Okay. I'll answer that quickly, but I would like to go back a few slides. So the earliest, like I said, we are making majority of our patients walking within 4 hours. That's thanks to the team approach here at Yashoda. We are using not only orthopedic surgeon, the pain team, the nurses, and also the nurses in the recovery. Most of us play a role.
Yes.
So earliest physio is about 3 to 4 hours, majority of walking, then they're sent to the ward. Right now, Sujatha, can you go back one slide, please? One more.
Preoperative.
Yes, fantastic. Now, she's got most of it. So please have a checklist. So always I give a checklist to most of my patients if you see the notes. So how to come prepared like you have done. So please, all of you have a checklist like this: fasting at least 6 hours minimum. And if it is upper limb, 6 hours, lower limb, if at all worst scenario is 4 to 5 hours. Part to preparation. This is the vital thing. Now that involves getting your barber and clipping, not shaving. Shaving increases the chance of infection. So always nowadays we are using the clippers, so please adhere to that. And then painting the part with betadine. Okay, I mean each surgeon has their own choice, so please find out what they want. My personal choice is 2 hours before surgery, clipping the area, then cover with betadine, and we leave the part like that. Okay. So usually if it's first thing 7 o'clock surgery, if I'm doing, I ask the patient to wake up at 5, have head bath or whatever bath, and then have with a normal soap. Then they come to you, you get the part clipped or, and then paint it thoroughly and leave it like that. You can leave the betadine to dry, that's not a problem. Okay, because we are going to take in the next half an hour. But you can't do that for the afternoon patient, do first thing in the morning. You want at least just maximum is 2 hours. Now continuing with the hypertensive, fantastic. And glycemic control, again, you have to ask them and you have to follow the chart. Yeah.
Yes.
And then prophylactic antibiotics, again, it depends on the hospital policy. Some give in the ward, some give in the operation theater.
Yes.
Majority of it, of us at Somajiguda, we are doing in the operation theater. Next one, please.
Sujatha, come to the post-operative, otherwise.
Perioperative, quick one, I'll finish up quickly. Now,
Yes.
perioperative is very important, the consent. Please remember, if it's a Telugu patient, you have to do that writing in Telugu. I write myself Telugu. Hindi patient in Hindi, English in English. We have on 2 sides of the consent sheet, English or Telugu. Majority of us do that. And also the signature, make sure it's all signed and marking. You need to mark the side of the limb because there are incidents that have happened. Instead of the left, the right one was operated. So this is a grave mistake. So it's a team's job. And coming to the intro, having the correct instrumentation. So always the nurse who is scrubbing, make sure that all the checklist is there. So I always give my list. Initially, when I joined Yashoda, I had a big file. I gave each procedure what all I'm expecting. Okay. So ask your surgeon if you're new, what they want. Absolutely. If at all you're girl, please make sure everything is tied back and your forehead is covered. We don't want your hand, beautiful hair. That should be there outside, not in the OT. Okay, and also no metals, bare elbow policy. Yeah, so we don't want anything. So please remember, we are doing somebody's mother or father. So I always think that's my mother or father. So if you don't want this to be done to your parents, you don't want to do for somebody else. So this is what we should feel. Yeah. Next, please go ahead, please. Yes, post-operative.
Yes.
Sorry, ma'am.
Yes, sir. Sorry, please go on, sir. We were talking about the ambulation and physiotherapy here.
Yes.
How early we can start ambulation and physiotherapy?
Yes. Now, regarding, you've got again beautiful presentation here, pain. Pain is the most important thing. Now, we still have some doctors in this hospital who say, abhi operation kiya na, darad to nahi hai to kya hai? That's all old things. Surgeons, big surgeons making big cuts. Abhi operation kiya to darad hota hai. No, things have changed. Okay, there is something called pain ladder. So you start off with the smallest possible painkiller, but if required, you have to go up the ladder, and which is well documented WHO also. So please liaise with the pain team, the pain nurse, and accordingly you have to use your wiseness to see what type of things we can help. The majority, like you have injections, you have patches, you can have ice pack, a bit of mobility. All these things help in pain. Yeah. And after the pain, you have all the beautiful fluid control, wound care, and all these things. And early ambulation, make sure that the patient is safe enough to be ambulated. If yes, please go ahead. Over to you, Sujatha.
Yes, sir. And coming to training parameters, and have to focus more on sterile draping and operating room arrangements, instrument interfaces with the surgical cart, and programming to the associate residents, and device maintenance. First focus on system training, and that includes electronic and mechanical troubleshooting as well as emergency shutdowns maneuvers.
So here I think you have already discussed the point of view on the operating the surgical unit system. But here we would like to also know who does the cross check, whether it is interfaced with the surgical cart. Is it you or your residents among your team or any nurse or any technician, sir?
Yeah, sure. So we have things designated to each role is designated. My OT nurse makes sure all the instruments are there, including all the robotic necessary equipment, including the disposable things. That's what she makes sure. And the biomedical guy make sure that the robo is functioning, and we have the OT technicians who switch on the machine, make sure that's functioning properly. Okay, so we have designated individual roles to each and every person. And then once everything is set up, that's when we make sure and then start the surgery.
Over to you, Sujatha.
Yes. Yes, ma'am.
So I think these are already well spoken. These training part. You wish to say something else, sir? Anything else you want to talk about this
Yes.
training part?
Now, first and foremost, I would like to say is we should be feeling blessed because we are one of the best hospitals in all over India. The reason I'm saying this is, see, I worked in London for 10 years. Now, when I started the robotic surgery 3 months ago, I put it on my Facebook. And can you guess, there are at least 5 surgeons from UK calling me up. They're all my friends calling me up. How does it feel to hold the robot? So they don't have a chance being in UK to even see or operate with the robot. So we are blessed to have the best possible technology in our hospital at Yashoda. That's number one. Number two, we have nowadays exposure to all over the world. So you want to excel. See, now you're all well-educated nurses. So you want to progress in your career.
Yes.
So if at all you're showing, you have to improve your CV. We call it curriculum vitae or resume. So every day you have to show an improvement. Somewhere you're learning some point. And also I would urge all of you to do some sort of research, some paper publication. See, if at all you plan to go abroad, you want to excel in your field, that is the way forward. So you have to show your technical skills and also your research skills to show that you are oriented towards your subject. So always please try to excel and you'll do very well. Sujatha, please.
Yes, sir. Coming to conclusion, robotic surgery can be performed safely with excellent results. Moreover, the damage is limited because of the high accuracy of the robots and benefits vary between indications. Yes, sir.
So I think we end the session today here, and it was very great learning and very interesting that we just felt that we should go on listening to you. I am sure that we are not going to end here because robots and robotic is such a vast orthopedic question where we can learn a lot of other things as well. So, sir, you would like to give any kind of your, tips or any message for the orthopedic scrub nurses? I'm damn sure that your orthopedic nurses also waiting down there to hear some guide from you.
All right. Okay. Now, first of all, I should thank you, Shanti, for making such a fantastic move. The reason being, this is what I was asking the hospital chairman, everybody, for a long time. And you have taken it much further than what I expected. You've done a fantastic job of doing such a nice study, including everybody, multidisciplinary approach, and getting Sujatha. She's done a good job in doing perfect slides and making it simple. So kudos to you, Shanti, that you have got all the different specialities, and now your nurses also, I'm sure they feel confident seeing all the specialities and simple tips. Yeah. And I tell all of you not to be fearful. See, we're all human beings. Don't be scared of anything. Just if you're not confident about things, go read up. See, early days, we had to go to the library, look at the books, all this is nonsense. Now you just have your phone on your hand. There's all this nonsense YouTube. Just go on to the Google. There are lots of search engines. PubMed it is called. If you're not sure about something, read up. The next day you'll come prepared. See, even now, some of the difficult surgeries that I do, I read up the day before or the night before. So that doesn't mean that I don't know anything. There's some things, we are all human beings, we don't know. So thanks to Shanti, so she was bringing all these things together in a nutshell for you. So she has done her job. Now I want you, all of you, to do your job. And remember, career is the only thing that is going to stay with you. We always hear, చదువుని ఎవరు దొంగలించలేడు, ఎంత చదివితే అంత మంచి. మిగతా అన్ని పోతాయి. ఇప్పుడు ఇవాళ నా దగ్గర డబ్బులు ఉండొచ్చు, రేపు పోవచ్చు, మళ్ళా రావచ్చు. బట్ చదువు అనేది ఎప్పటికీ పెరుగుతూనే ఉంటుంది అని తరగదు. I suggest all of you to please concentrate on your careers. So you should have a work-life balance. See, yesterday I was reading, the best country to live in is Stockholm. You know, the work-life balance is 75. People are very happy there. The next one is in Finland. So all these European countries, they have a good work-life balance. You have good time. Again, you consider your career, earn enough. So these are the things you should concentrate on. And I wish you all the best. Thank you, Shanti.
Thank you, sir. Well enough. We will definitely take your tips and we'll wish that, we again next month also we will like to hear from you because this is not the end of the session. And thank you so much in spite of your very, very busy schedule and as well the core night OPDs, you have contributed so much. Thanks to you, sir. And thank you, Sujatha, for your beautiful presentation. Thanks, everyone. Next Thursday, again, we are coming with one more good orthopedic topic. Till then, stay safe and stay good. Thank you.
Thank you. Have a good day, all of you.
Thank you, sir.